So I wanted to thank the committee for inviting me to share my presentation in this nice conference. So before I start, I wanted to ask how many people here are posterior segment surgeons? Can you raise your hands? Posterior segment surgeons? 5, 6. Okay, so the topic of my presentation actually has two arms to it. For anterior segment surgeons, sometimes the anterior segment surgeon does the phaco without addressing the primary problem, the primary pathology, without telling the patient that he did not solve the problem if he was a diabetic patient with fractional detachment or vitreous hemorrhage, which is a problem. As for us, posterior segment surgeons, vitreoretinal surgeons, when we encounter these types of cases, you know, the diabetic patients with diabetic retinal complications, we have a debate. It's very controversial whether we should preserve the lens or that we should do the phaco in the primary surgery. Of course, a lot of vitreoretinal surgeons prefer to preserve the lens in the primary setting for very obvious reasons that I'm going to mention later on in my presentation. However, a lot of surgeons as well like to do the phaco in the primary setting with the vitrectomy for, again, some valid reasons that I'm going to share later on in my presentation. So I'm going to present a series of cases that hopefully would help us reach a verdict by the end of my presentation whether or not we should perform phaco in the primary setting in patients with diabetic complications. So this is the first scenario, of course, the dense vitreous hemorrhage. I think this is a problem that encounters us when doing the primary in phaco in cases with dense vitreous hemorrhage. I have two cards in my armamentarium that I like to play. Of course, first of all, staining the anterior capsule with trypan blue is very, very helpful. The second option is actually inserting the chandelier illumination through the infusion trocar. Gives us a very bright red reflex, as we can see. Makes the surgery quite easy and very much less troublesome. As we can see, I was able to do my rexes, and then I proceeded with the phaco. Very nice and obvious red reflex, as we can see. Another problem with the dense vitreous hemorrhage, as we can see this case, I decided that I want to preserve the lens. Of course, the hemorrhage was very dense. Midway through the surgery, I found that I was not having a very ideal view. So I decided, why not go for the phaco now? Of course, the problem in this case, once the lens gets opacified due to hyperosmolarity, and you decide to go with the phaco, the eye is very hypotenuse. As we can see, I had an extended rexus, and midway through the phaco, I found that the nucleus was starting to tumble. I proceeded with the phaco. Fortunately enough, it was not very dense. So when I had dropped fragments, I easily was able to eat it with the vitrectomy cutter, and I proceeded with the rest of my vitrectomy. I did the shaving, and of course, because the patient had very dense vitreous hemorrhage, the vision improved dramatically after the surgery. Of course, here I assessed the sulcus. I made sure that I had very intact sulcus, and I implanted the PMMA within the sulcus, and I concluded my surgery. Of course, these cases, because they have very high hyperosmolarity, the diabetic cases, the lens tends opacified by the end of the surgery. Second case scenario is when you do not, actually preserving the lens is not an option. You have to actually do the phaco. This case, as we can see, it had a very dense cataract, not only the cortical element, but as well the posterior subcapsular element. So I did the phaco, very routine case, straightforward case, as we can see. Uneventful, and I implanted the IOL within the bag. I proceeded with the phaco. Of course, this was a type 1 diabetic female. She had a very, very ischemic retina, as we can see. She had very aggressive membranes, and I gave her an idea about the prognosis of the case. I told her, your retina is very ischemic, and the prognosis will not be that good. I dissected the membranes manually, as we can see. Unfortunately, about 3 days post-operatively, I get a phone call from the resident telling me that the patient is presenting at the ER with severe pain. For some reason, the resident had diagnosed the case to be endophthalmitis. I do not know why, but when I connected the dots and I had an idea what the problem would be. The patient had severe pain, of course, and even though, as we can see, I had dissected all the membranes through the surgery, and I did very, very aggressive laser because I knew that the retina was extremely ischemic. When the patient presented 3 days post-operatively with severe pain, this was the picture. The patient had very, very aggressive rubeosis iridis, as we know, because the retina was extremely ischemic. The retina was extremely ischemic, and the new vessels encroached on the iris very, very quickly post-operatively. Unfortunately, these cases have very, very high IOP, 50s and 60s, and you must have very low threshold to perform intravitreal anti-VEGF injection as well as cyclodiode, because the IOP tends to get the best of the optic nerve within a very, very short period of time. So now this is a case where doing the phaco is actually an elective choice. The lens was not, the cataract was not that significant, that dense as we can see. He had a nuclear sclerosis, but fortunately enough, I had the luxury of actually injecting him anti-VEGF prior to the surgery. So I was like, why not go for the phaco and do very nice vitreous-based shaving? Because as we all know, diabetics, the hyaloid is not forgiving. If you tend to leave any remaining hyaloid under the silicone, it tends to proliferate and forms very aggressive membranes that might sacrifice the success of your surgery. So now by this point, I think I have mentioned 3 pros to actually performing phaco surgery in the primary setting and 2 cons. Of course, the pros that you can do very nice vitreous-based shaving. In this case, as we can see, I tackled the membranes up to the periphery. I had no problem actually being afraid of injuring the lens. And I'm working in an optimal, I did the phaco in an under optimal circumstances. However, of course, the things that are against doing the phaco in the primary setting, of course, first of all, the very high incidence of rubeosis iridis. The second problem is that actually the pupil does not tend to dilate well. And of course, when working with very dense vitreous hemorrhage, the red reflex is not that nice. As we can see, I was able to tackle the membranes up to the periphery. And I did good laser. And I concluded my surgery. This patient's vision dramatically improved. Fortunately, alhamdulillah, he did not have any rubeosis postoperatively because I had injected him anti-VEGF prior to the surgery, as well as his retina was not that ischemic as the other patient. So my take-home message, of course, you should tailor your pars plana vitrectomy on a case-to-case basis. Some cases you can decide to do the phaco and have a good heart about it, and some cases you should not do the phaco under any cost. The other option is if you have the luxury of actually injecting anti-VEGF prior to the surgery, you must do it because you will need it. As we can see, the rubeosis is very aggressive and it's a very devastating complication. The third thing is, of course, you should have a very low threshold to performing retinal photocoagulation in the fellow eye, because if the retina was lost to a pathology in one eye, the other eye will usually follow. And of course, you should always give the patient an idea about the prognosis of the case, especially the type 1 diabetics. They should know that the prognosis is not that good as long as they are not controlling their blood sugar, because it's not only the surgeon's responsibility, it is as well the responsibility of the patient. Thank you.